Thanks for joining us for another Contagion Coronavirus video. Today we're joined by Dr. Ryan Stevens, who is a member of the Society of Infectious Diseases Pharmacists and recently presented a webinar on convalescent plasma. Thanks so much for joining us.
Sure.
So let's just get started. Can you describe the mechanism of action of convalescent plasma?
Sure. So convalescent plasma and the idea of giving it as a therapeutic for viral infections, it really stems from the idea of harvesting the adaptive immune system of one patient and then passing that to a second patient who's in the acute viral phase of the illness. So essentially, you take a patient who's had an infection with the virus and has recovered, that has been presumed or proven to have produced antibodies to that pathogen. In the case of SARS-CoV-2, this antibody development, it generally takes place with seroconversion somewhere between 8 and 21 days since the beginning of the infection. And so after this person has been proven to have the infection and has fully recovered, you take their blood and you harvest plasma from the blood by apheresis. And then this plasma is then administered to a second patient who's in this sort of acute viral phase of the illness, thereby sort of passing the adaptive immune system from patient 1 on to patient 2.
So how has convalescent plasma been used for other infectious diseases and specifically for other coronaviruses?
Yeah, so there's a lot out there on this. That would make sense because convalescent plasma is really probably one of the oldest therapies in infectious disease we have. It dates back into the pre-antibiotic era. As far as like 1892, when it was used for the treatment of diphtheria, with serum actually being harvested from various animals. And over the years, it's been used for a lot of different infections, from the Spanish flu to measles and pertussis. But most recently, it's been used in 4 viral illnesses since the year 2000. So one is influenza A, H1N1 in 2009, and one is Ebola in 2015. But for the sake of what we're talking about here with SARS-CoV-2 and COVID-19, we should look at it in the context of other coronaviruses. So that would include SARS-CoV-1 in 2003, and then the Middle Eastern Respiratory Syndrome coronavirus in 2012. So with regards to SARS-CoV-1, in 2003 outbreak in Hong Kong, there's a study where they administered convalescent plasma to 80 patients with SARS-CoV-1. And they looked for the primary outcome of discharge from the hospital by day 22. And they found that 33 of their 80 patients met this primary outcome, it's about 41%. And there were 2 important findings that came out of this study with regards to the use of convalescent plasma. So the first is that they found that patients that received convalescent plasma within 14 days of the onset of their symptoms were more likely to reach the primary outcome of discharge by day 22. And this would make sense given that we know that the coronaviruses have sort of 2 immediate phases. The first is this viral phase where the virus is present. The second is more of an immune activation phase. So it would make sense that patients that got the convalescent plasma during the viral phase have a better outcome. And then the second finding that they found was that patients that were PCR positive by a nasopharyngeal PCR, but seronegative for antibodies at the time they received the convalescent plasma were actually more likely to reach the primary outcome as well. And again, this makes sense because we're passing the adaptive immunity from one patient onto a second. So if the second patient hasn't developed their own active immunity yet, it would make sense that they would be more likely to potentially experience this good outcome of discharge by day 22. If we look at the Middle Eastern Respiratory Syndrome coronavirus, MERS, there's some interesting data that came out of that as well. So in one very, very small study, they administered convalescent plasma to 3 patients with MERS-CoV. And they looked for the rate of early seroconversion. So seroconversion of the recipient within a few days after administration of the convalescent plasma. And what they found was that there was only one of the 3 patients that actually had early seroconversion. And that one patient was also consequently the only patient who received convalescent plasma with a neutralizing antibody titer of greater than or equal to 1 to 80. And so the important finding that came out of this study is the idea that the neutralizing antibody titer of the donor may actually impact the seroconversion and thereby potentially the immunity of the recipient.
So what do we know so far about convalescent plasma for COVID-19?
Well, what we know is relatively limited. So our knowledge of convalescent plasma and its efficacy in SARS-CoV-2, or the treatment of COVID-19, comes from 3 very small studies. Well, 2 were small uncontrolled studies, and 1 was just a case series. And this is a cumulative 19 patients across these 3 papers. And all patients that received it, all 19 of them, were either severely or critically ill at the time they received the convalescent plasma. And the regimens that they received varied widely depending on the paper that you're reading that was performed. So one used a single unit of convalescent plasma, which is about 200 milliliters, with a no neutralizing antibody titer of greater than 1 to 640. That's a very high neutralizing antibody titer. The second used 400 milliliters, which was administered as 2 separate 1-unit infusions with a neutralizing antibody titer of 1 to 40, or greater than 1 to 40, and an IgG titer of greater than 1 to 1,000. And then the third study didn't actually check titers of the donors or the specimens, but they administered sort of non-standard volumes. This was more of a case series, and so they administered anywhere between 200 and 2,400 milliliters of convalescent plasma. Another important thing to note is that most of the patients we have experienced with to date have received concomitant antiviral therapy, be that lopinavir, ritonavir, hydroxychloroquine, other therapies at the same time or before receiving convalescent plasma. And corticosteroid receipt is also very common in this population. So if we look at the duration of symptoms before they presented to the hospital, all 19 presented within roughly 2 to 4 days of the development of symptoms, and all received convalescent plasma therapy within about 12 to 20 days since the onset of symptoms. So all of these patients or papers report various forms of clinical, radiographic, or virologic outcomes, and all of them report sort of favorable outcomes. But some of the things that were reported were things like resolution of radiographic infiltrates, or improvement in symptoms and clinical symptoms as defined by various symptom scores, and improvements in inflammatory markers like CRP and interleukin-6, IL-6, and increases in antibody titers in recipients. They've also reported, one of the studies specifically reported the rate of conversion of the nasopharyngeal PCR to a negative result, which also showed favorable outcomes. And most notably is that all 19 of these patients survived at the time that the papers were written, which may represent a little bit of reporting bias, but I think is an encouraging finding. It's important that we note, though, that all of these things, or all of these papers to date, they all lacked control groups. And there was a lot of other confounders that I've mentioned, like concurrent antiviral therapies or the variability in different regimens. And so we have to interpret the data with caution, but I think when we couple these 19 cases with the data we have from SARS-CoV-1, I'm optimistic about the use of convalescent plasma at this point.